morning. So we have about 1 hour. Let's see how many questions we can do. A 33-year-old male presents to the general practice with a 1-week history of pain and swelling in his left knee and right ankle. On examination, his knee and ankle are erythematous, swollen, and tender. His observations are normal. He has a past medical history of ulcerative colitis, gastroesophageal reflux disease, and depression. A rheumatological screen is performed which shows the following. CRP is high, ESR is high, rheumatoid factor is low, normal, anti-CCP is normal, ANA negative, ANCA negative. Pain and swelling left knee, right ankle. Sounds like asymmetrical polyarthralgia, polyarthritis. On examination, his knee and ankle are erythematous, swollen, tender. He has ulcerative colitis. So what's going on? The GP refers the patient to rheumatology, where further tests are performed. Which of the following tests are most likely to be positive? So first you need to know what this joint problem might be, and then what will be positive for that joint problem. What joint problem is associated with ulcerative colitis? And it's seronegative because anti-CCP is low, rheumatoid factor is low, so it's a seronegative spondyloarthritis. No, spondylo is spine. It's not spondyloarthropathy. It's seronegative asymmetrical polyarthritis. What is this? 33-year-old male associated with ulcerative colitis. CRP ESR is high. I don't know what this is. Let's look at this. Anti-Jo1 is for antiphospholipid syndrome, is it? HLA-B51, I don't know. HLA-B27, I think this is for seronegative spondyloarthropathies. This is seronegative, so I'm gonna guess this gene is involved. Anti-DNA is for more specific for SLE. This doesn't sound like SLE. Anti-cardiolipin, I think it's for antiphospholipid syndrome as well. And it can also be positive in people with syphilis. B51, I don't know what's that associated with. Okay, let's guess B27, and the answer is B27. So this is enteropathic arthritis. Enteropathic arthritis is associated with ulcerative colitis. It's a seronegative spondyloarthropathy. Oh, it's a spondyloarthropathy, but I thought spondylo means spine. Spondylo, vertebra, meaning vertebra, but it's not affecting the vertebra, so I guess it's a misnomer. This patient has presented with signs of asymmetrical inflammation of peripheral joints with a background inflammatory bowel disease. This points towards a diagnosis of enteropathic arthritis. Enteropathic arthritis is seronegative, rheumatoid factor negative. Therefore, the patient's blood results are consistent with this. They are significant only for raised inflammatory markers. Seronegative spondyloarthropathies are associated with HLA-B27. Therefore, this is the correct answer. Anti-Jo1 antibodies are associated with polymyositis. So I was wrong. It's not antiphospholipid. It's polymyositis. HLA-B51 is associated with Behçet's disease, the one where smokers get it, and you get necrosis of your lower limbs. I think, is it? Is that the one? No, that's Buerger's disease. Behçet's disease is the one where you get repeated ulcers in the mouth or genitalia. Behçet's disease, so-called Behçet syndrome, is a rare disorder that causes blood vessel inflammation throughout the body. It's Mayo Clinic. Wikipedia would be better than Mayo Clinic. It's a type of inflammatory disorder which affects multiple parts of the body. The most common symptoms include painful mouth sores, genital sores. Yeah, it's the one with lots of mouth ulcer, genital ulcer, inflammation of parts of the eye, and arthritis. So that's HLA-B51. What's polymyositis? Oh, yes, that's the polymyositis and that's dermatomyositis, right? It's like almost the same. Oh, Osmosis has a video. Let's have a look. Don't have it here. Polymyositis. Spelling it correctly, right? Yeah, somebody downloaded it.
In polymyositis, myos refers to the muscles, poly means many, and itis refers to inflammation. So polymyositis is an inflammatory disorder which involves many muscle groups around the body. Polymyositis is an immune-mediated disease, meaning that the immune system attacks the muscles in our own body. Normally, the cells of the immune system are ready to spot and destroy anything foreign that could cause the body harm. To help with this, most cells in the body have a set of proteins that combine together to form something called a major histocompatibility complex, or MHC, class 1 molecule that sits on the surface of their cell membrane. These surface proteins act kind of like a serving platter, presenting molecules from within the cell for the immune system to continually sample. Normally, though, the molecule is just a sample from the cell, and the immune system recognizes it as harmless, and this is known as a self-antigen, and in this case, there's no immune response. But when a cell is actually invaded by a pathogen, like a virus, viral antigens from inside are presented on the MHC class 1 molecule, and that sparks an immune response. A type of T lymphocyte called a CD8-positive T cell, also known as a cytotoxic T cell, uses its T cell receptors to bind to the antigen presented by the MHC class 1 molecule. If the cytotoxic T cell binds strongly, then the antigen is recognized as foreign, and the cytotoxic T cell secretes a whole lot of perforin and granzymes. Perforin forms big holes in the infected cell, and that allows granzymes to enter the cell. Once inside, the granzymes induce apoptosis, or programmed cell death. And as if that weren't enough, the cytotoxic T cells have a protein called Fas ligand on their surface, and it binds to a molecule called Fas on the surface of the infected cell. When these two combine, it triggers a cascade of signaling events inside the target cell that also leads to apoptosis. Meanwhile, B lymphocytes that react to the pathogen can also start producing a whole lot of antibodies. These antibodies bind to the pathogen, and typically prevent it from attacking the host cells and at the same time tag the pathogen for further destruction by other immune cells. In polymyositis, healthy muscle cells present normal muscle proteins on the MHC class 1 molecule, but the cytotoxic T cells inappropriately react to them, and they get activated. That's because it's thought that the muscle proteins might look similar to a foreign pathogen. And this is called molecular mimicry, because from the perspective of the cytotoxic T cell, the host protein is mimicking a foreign protein. When our own protein triggers an immune response, that protein is called an autoantigen. So when the cytotoxic T cells are activated by the autoantigen, they cause apoptosis of the muscle cells. In some cases, B cells start producing antibodies against these autoantigens as well. The specific antigenic targets in polymyositis include tRNA synthetases, also called JL1, a nuclear protein known as Mi2, and components of the signal recognition particle, or SRP for short, which helps with protein trafficking within the cell. The immune reaction causes inflammation in and around the muscles that are being attacked by the immune response, and typically these attacks happen repeatedly over time and can involve different muscle groups, and also called these autoantigens as well. The specific antigenic targets in polymyositis include tRNA synthetases, also called JL1, a nuclear protein known as Mi2, and components of the signal recognition particle, or SRP for short, which helps with protein trafficking within the cell. The immune reaction causes inflammation in and around the muscles that are being attacked by the immune response, and typically these attacks happen repeatedly over time and can involve different muscle groups. The destruction of muscle cells can lead to muscle weakness, and can cause muscle enzymes like aldolase and creatine kinase to spill into the blood. Because it's an autoimmune process, it's also possible for polymyositis to happen alongside other autoimmune connective tissue diseases, including Sjogren's syndrome, rheumatoid arthritis, or scleroderma. Symptoms of polymyositis usually include bilateral weakness and muscle wasting that mostly affects proximal, big muscle groups, like the shoulders and hips. and usually spares the distal muscles like muscles in the hands. Individuals might have difficulty rising from a chair, lifting their arms, climbing stairs, or combing their hair. Sometimes these muscles might be tender or painful. In severe cases, the muscles of the pharynx or the esophagus are involved, and this causes dysphagia or difficulty in swallowing. Diagnosis is based on identifying myositis-specific antibodies, like anti-JO1, as well as elevated serum levels of muscle enzymes like aldolase or creatine kinase. Additionally, electromyography can be used to detect regions of dead muscle cells that cause abnormal electrical signal conduction. A muscle biopsy can also show inflammation in varying stages of necrosis. Treatment of polymyositis typically focuses on suppressing the immune response, usually with corticosteroids. In addition, specialized exercise therapy can help maintain muscle function. Alright, as a quick recap. Polymyositis is an inflammatory disorder of the muscles, caused mainly by cytotoxic T cells destroying muscle tissue due to molecular mimicry, and this results in bilateral proximal muscle weakness of large muscle groups. Its diagnosis involves elevated serum creatine kinase, as well as anti-JO1 antibodies, and it's treated with corticosteroids.
Okay. Next question. A 4-year-old boy is brought to the GP by his mother, who states that she has noticed a barking cough a few times every day for the last 2 days. Sounds like croup. There has been no change to his appetite and his behavior has not changed. The GP does not find any abnormalities on examination. Given the likely diagnosis of mild croup, what would be the first-line treatment? I think in croup you give steroids, right? Prednisolone or dexamethasone? Both are steroids. Which one is in the guidelines? Nebulized adrenaline, maybe in severe cases. Ouch. Benzalpenicillin, croup is caused by parainfluenza virus, so antibiotics wouldn't work against it, right? I think it's oral dexamethasone. Wait, oral prednisolone. Prednisolone is given orally. Dexamethasone is usually given intramuscularly or intravenously, I think. Ibuprofen, it's an NSAID. I don't know about giving NSAIDs in kids unless it's very severe pain but has side effects. Okay. No, the answer is oral dexamethasone. Croup, a single dose of oral dexamethasone is to be taken immediately regardless of severity. 0.15 mg per kg. The barking cough and absence of stridor or systemic symptoms points to a diagnosis of mild croup. Let's read a bit about croup. So croup is a form of upper respiratory tract infection seen in infants and toddlers. It is characterized by stridor, which is caused by a combination of laryngeal edema and secretions. Parainfluenza viruses account for the majority of cases. Epidemiology: peak incidence at 6 months to 3 years, more common in autumn. Features include stridor, barking cough worse at night, fever, and coryzal symptoms. Clinical knowledge summaries suggest using the following criteria to grade the severity. You have mild, moderate, and severe. Mild is characterized by occasional barking cough, no audible stridor at rest, no or mild suprasternal and or intercostal recession. The child is happy and is prepared to eat, drink, and play. Moderate severity croup is characterized by frequent barking cough, easily audible stridor at rest, suprasternal and sternal wall retraction at rest, no or little distress or agitation. The child can be placated, and is interested in its surrounding. I think placated means you can calm them down. Severe is characterized by frequent barking cough, prominent inspiratory and occasionally expiratory stridor at rest, marked sternum wall retractions, significant distress and agitation or lethargy or restlessness, a sign of hypoxemia. Tachycardia occurs with more severe obstructive symptoms, and hypoxemia. CKS suggests admitting any child with moderate or severe croup. Other features which should prompt admission include the child is less than 6 months of age. Remember, peak incidence is 6 months to 3 years. Known upper airway abnormalities, for example, laryngomalacia, Down syndrome. Uncertainty about diagnosis. Important differentials include acute epiglottitis, bacterial tracheitis, peritonsillar abscess, and foreign body inhalation. Investigations. The vast majority of children are diagnosed clinically, however, a chest x-ray is done. If a chest x-ray is done, a posterior anterior view will show subglottic narrowing, commonly known as the stipple sign. In contrast, lateral view in acute epiglottitis will show swelling of the epiglottis, the thumb sign. Is this only in acute epiglottitis or also in Croup? Management. CKS recommends giving a single dose of oral dexamethasone, 0.15 mg per kg to all children regardless of severity. Prednisone is an alternative if dexamethasone is not available. What's the difference between prednisone and dexamethasone? Emergency treatment. High flow oxygen, nebulized adrenaline. Hold on, let me check my timetable. Okay, I'm back. What was I saying? Okay, the difference between prednisone and dexamethasone, right? The prednisone or prednisolone? Oh, this is a study showing which one is more effective. Conclusion: single oral dose of prednisone is less effective than a single oral dose of dexamethasone in reducing unscheduled representation to medical care in children with mild to moderate croup. So in croup, dexamethasone is more effective. Is this website reliable? Dexamethasone, corticosteroid, steroid medication, rename, prednisolone. Main differences: drug class same, brand, generic status, generic. What's the brand name? What form? What standard dose? It's too layman. You're talking about COVID, huh? And then down here you quote studies on asthma. Strange. Prednisone versus dexamethasone. Use of dexamethasone and prednisone. I think dexamethasone is stronger than prednisone, right? I think Osmosis has notes. No, not Osmosis, Passmed has notes. prednisolone, they're all corticosteroids. Here, dexamethasone is a synthetic glucocorticoid whose anti-inflammatory potency is 7 times greater than prednisolone. So that's the reason, it's 7 times more potent than prednisolone. So you're gonna give much stronger corticosteroid, 0.15 mg per kg of dexamethasone. Okay. Is this even osmosis? It doesn't look like osmosis. I think it's Armando has to do that. Yeah.
Croup, also known as laryngotracheal bronchitis, is usually a self-limiting upper airway viral infection. As the name suggests, there is an inflammatory response occurring in the larynx and trachea, causing upper airway obstruction. Now, this leads to the characteristic features of croup: a hoarse voice, barking cough, inspiratory stridor, and increased work of breathing. Croup is the most common infectious cause of airway obstruction in children, usually between 6 months to 3 years of age, and is more common in boys than in girls. The most common cause of croup are the parainfluenza virus 1 and 2. Respiratory syncytial virus is another cause of croup. Respiratory syncytial virus is the main cause of bronchiolitis. Although acute viral infections are the most common cause of croup, bacterial and atypical agents have also been identified. The respiratory tract begins with the nasal cavity and the oral cavity. Oxygen inhaled travels through this area, the pharynx, the larynx, and then towards the lower respiratory tract. The lower respiratory tract begins with the trachea. The trachea bifurcates into the bronchi, and then smaller bronchi, and then bronchioles, before terminating as an alveolus. The larynx is also known as the voice box. It has many functions, including phonation, the cough reflex, and protection of the lower respiratory tract. In croup, the larynx, trachea, and bronchi are inflamed. That is why croup is called laryngotracheal bronchitis. The pathophysiology typically begins with an upper respiratory tract infection over a few days, low-grade fevers, and coryza. After a few days, the parainfluenza virus will infiltrate the larynx and the trachea, causing an inflammatory reaction. It infiltrates the cells in this area, causing increased infiltration of actual white blood cells to the area, which will lead to pain and edema. The swelling results in partial airway obstruction, which, when significant, results in dramatically increased work of breathing and the characteristic turbulent, noisy airflow known as stridor. Stridor is mainly heard in inspiration because the pressure in this area drops below atmospheric pressure, causing collapse of the airway, resulting in further turbulent flow or air through this narrow airway. In summary, viral croup develops over days with an upper respiratory tract infection with low-grade fever and coryza, and this is followed by a barking cough and various degrees of respiratory distress. In most children, the symptoms subside quickly with resolution of the cough within 2 days. Croup is the clinical syndrome of hoarse voice, barking cough, inspiratory stridor, and respiratory distress. Croup can be classified into mild, moderate, or severe depending on clinical presentation. If the child presents cyanosed with decreased level of consciousness, this is life-threatening and immediate resuscitation is warranted. There needs to be oxygen and nebulized adrenaline to help reduce the swelling in the respiratory tract. Mild croup typically has a barking cough without inspiratory stridor. Moderate croup presents with increased respiratory effort and resting stridor. Increased respiratory effort can be identified with signs including a tracheal tug and intercostal recessions. The child is still alert and active. A single dose of steroids such as dexamethasone is recommended in all patients with croup, including those with mild disease who present to the hospital. Moderate disease requires steroids or nebulized adrenaline if steroids are not tolerated. Severe airway obstruction have all the signs and symptoms I mentioned earlier. The stridor is persisting and the child is usually very apathetic or restless. There is marked tracheal tug and chest wall recession. Severe stridor requires oxygen most likely, steroids and nebulized adrenaline to open up the airways. Soft stridor, irritability, tachycardia, pallor indicates imminent airway obstruction. It's important to monitor children with croup. If there's no improvement, consider alternative diagnosis. Differential diagnosis for croup include an inhaled foreign body, congenital abnormalities, epiglottitis, bacterial tracheitis, and even anaphylaxis. Croup is a clinical diagnosis. Essentials for diagnosis are gradual onset of symptoms, barking cough, and stridor. Rarely investigations are warranted. If an X-ray is performed, there is the steeple sign. The steeple sign is a radiological sign found on a frontal neck radiograph, where subglottic tracheal narrowing produces the shape of a church steeple within the trachea itself. Some children may have many episodes of croup, and these children might be otherwise well, and the croup will settle really quickly. This is probably called a spasmodic croup. Spasmodic croup comes on rapidly overnight in children who are perfectly well when they went to sleep. Spasmodic croup often runs a short course and is usually associated with asthma and atopy. Thank you for watching.
Okay, next question. Oh, here, I haven't finished the management. Emergency treatment includes high flow oxygen and nebulized adrenaline. Next question. A 20-year-old woman attends the emergency department with right-sided back pain and dysuria, which has been present for the last 2 days. The pain is severe and constant and radiates around from her renal angle to her groin. The typical loin to groin pain of renal stone? Could still be pyelonephritis. On examination, her temperature is 38.1 degrees Celsius, more indicative of pyelonephritis. It's a high temperature. Her heart rate is 101 beats per minute. Her blood pressure is 139/91, and she has a palatable mass on the right side of her abdomen with a tender renal angle. Which of the following investigations is most appropriate to investigate her abdominal mass? So you want imaging, right? Urine dip. We'll see if the urine has any white blood cells, glucose nitrates, or any blood or protein. However, you want to explain the mass. Abdominal plain abdominal X-ray. You won't be able to see much detail on the kidneys. Maybe you can see the outline, the shape, but nothing much other than that. Furthermore, it's only a 2D image. IV urogram. IV urogram, you can only see the pelvis and the ureters. However, it's possible that it's a suitable investigation if the renal mass is due to hydronephrosis from reflux due to a stone. Over here we don't know, right? CT abdomen and pelvis with contrast. What's the use of the contrast? CT abdomen pelvis would be good, but how about with contrast? Are you looking for renal stones? If you're looking for renal stones, contrast would sort of with the contrast interfere with the stone, with visualizing the stone. Okay, let's look at the vignette again. Okay, 20-year-old emergency department, right-sided back pain and dysuria. So definitely there's a UTI here, which has been present for the last 2 days. The pain is severe and constant and radiates. Severe and constant, so probably not a renal stone. Renal stone usually comes and goes. It's not constant, right? Radiates around her renal angle down to her groin. Still could be a renal stone. Different people have different ways of experiencing pain. On examination, the temperature is 38.1, heart rate 101, blood pressure high. Normal, almost reaching stage 1, but in acute pain, so should be normal. Palatable mass on the right side of her abdomen with tender renal angle. CT abdomen pelvis would be compared to ultrasound will show a more objective imaging because ultrasound is very operator dependent. However, ultrasound doesn't involve radiation. I'm gonna guess CT abdomen pelvis with contrast. If it's polycystic kidney disease, you can see clearly. Ultrasound also can though. If it's hydronephrosis due to obstructed ureter, renal stone. Can also see let's say CT abdomen pelvis contrast, just because it can give you more objective and more detailed view. No, the answer is ultrasound. So ultrasound is the best diagnostic investigation for hydronephrosis. So here we already concluded that it's hydronephrosis. Given the history, the likely diagnosis here is a ureteric stone causing obstruction of the right kidney and leading to hydronephrosis. This would be present as a palatable mass on examination. The best investigation in the first instance would be an ultrasound of the renal tract, although it cannot directly show a stone, it is the best way to show if the renal tract is obstructed in any way. The first line treatment for this would be a nephrostomy in the first instance, which again would be ultrasound guided. Before doing further investigations, it is also always good practice to avoid irradiating a patient if possible, especially in those under 20 or women of childbearing age. Okay, issue of radiation. If a diagnosis of hydronephrosis is made, a nephrostomy is performed to treat this. Then you would consider performing investigations to look for the cause of her obstruction. This would be a CT abdomen and pelvis without contrast. Without contrast. Contrast agents and water soluble are water soluble and therefore get filtered into the urine and opacify the contents of the ureters. As stones appear the same density and as contrast agent, it makes them effectively invisible to the scan, and so a CT with contrast in this situation will be of no more help than an ultrasound in making a diagnosis. The same rules are true for an intravenous urogram, although it is of even less help as, unlike a CT or ultrasound, it does not provide a three-dimensional images and so does not allow a good assessment of the kidneys. Although it is sometimes possible to see stones on an abdominal plain film, it would provide no information about the kidneys and therefore is pointless in the first instance. A urine dip is helpful, as if blood is seen, it could suggest some stone pathology, but it certainly would not help in telling you the cause of the palatable mass. So the reason is ultrasound is more suitable is because she's young, she's a woman of childbearing age. You want to minimize radiation. That's like the minor reason, but the main reason is because you want to know whether there is hydronephrosis or not first, and then if there's the hydronephrosis, you want to do a nephrostomy, which is draining the urine straight from the renal pelvis to relieve the obstruction temporarily. Then after that, you can do further investigation to investigate the cause of the hydronephrosis. So it's like a stepwise thing. And furthermore, this one is because it's CT abdominal pelvis with contrast. Although you will be able to see like very detailed soft tissue imaging, however, you will not be able to see the stone because the contrast will interfere. It's the same opacity as the stone in a CT abdomen. So ideally you would do without contrast instead. Okay. Ultrasound first line. Okay. Next question. A 19-year-old type 1 diabetic attends the emergency department with diabetic ketoacidosis. 1 liter of 0.9 saline has been given and you are asked to set up an insulin infusion for the patient. What is the correct rate of insulin you should prescribe according to current NICE guidelines? think it's 0.1 units per kg per hour. So is it here, 0.1 unit per kg per hour? Yep, that's just something you have to memorize. It's in the guidelines. Should I go and look at DKA guidelines? DKA management nice guidelines. Basically, you need to give fluids, you need to give potassium replacement, need to give insulin infusion, fixed rate insulin infusion until the glucose is a certain level. I need to memorize all this actually. Overview. I guess the pathways will do this. Children and young people though. What about adults? Recognition, referral, and diagnosis. Measure capillary blood glucose at presentation in children and young people without known diabetes who have increased thirst, polyuria, recent unexplained weight loss, excessive tiredness, and any of nausea, vomiting, abdominal pain, hyperventilation, dehydration, or reduced level of consciousness. For children or young people without known diabetes who have a plasma glucose level of above 11 and symptoms that suggest DKA, suspect DKA immediately and send them to hospital with acute pediatric facilities. Be aware that children and young people taking insulin for diabetes may develop DKA with normal blood glucose levels. Suspect DKA even if the blood glucose is normal in a child or young person with known diabetes and any of the following: nausea or vomiting, abdominal pain, hyperventilation, dehydration, reduced level of consciousness. When DKA is suspected in a child or young person with known diabetes, measure their blood ketones, beta-hydroxybutyrate, using a near-patient method if available. Immediately send them to a hospital with acute pediatric facilities if their blood ketones are elevated. A near-patient method for measuring their blood ketone is not available. If DKA is suspected or confirmed in a child or young person, explain to them and their families or carers that DKA is serious and they need urgent hospital assessment. When a child or young person is suspected or known DKA arrives at hospital, measure their capillary blood glucose, capillary blood ketones, beta-hydroxybutyrate if near patient testing is available, or urine ketones if it's not, capillary or venous pH, and bicarbonate. Diagnose DKA in children and young people with diabetes who have hypoglycemia, plasma glucose more than 11, and acidosis indicated by pH below 7.3 or plasma bicarbonate below 15, and ketonemia indicated by blood beta-hydroxybutyrate above 3, or ketonuria 2+ and above on a standard strip marking scale. Diagnose DKA severity as follows: mild DKA if pH is below 7.3 or plasma bicarbonate is below 15, moderate DKA if pH is below 7.2 and bicarbonate below 10 or bicarbonate below 10, severe DKA if pH below 7.1 or bicarbonate below 5. So diagnosis when they have symptoms such as polyuria, polydipsia, abdominal pain, vomiting, diarrhea, spasmodic breathing, ketotic breath, all that. You take a blood glucose. If blood glucose more than 11, suspect DKA, sent to hospital. And then in hospital, you want to measure blood glucose. You want to measure blood ketones, either capillary or urine. and also the pH, either capillary or venous. Then you diagnose DKA based on the blood glucose reading more than 11, pH less than 7.2, or bicarbonate less than 15, and blood ketones more than 3 millimoles per liter or more than 2 plus on urine dipstick. Initial management. Inform the responsible senior clinician when a child or young person is diagnosed with DKA. Explain to the child or young person and their family or carers what DKA is and what care they may need. When DKA is diagnosed in a child or young person in hospital, record their level of consciousness, heart rate, blood pressure, temperature, respiratory rate. Look for cosmos, breathing, history of nausea or vomiting, clinical evidence of dehydration, body weight. When DKA is diagnosed in a child or young person in hospital, measure and record the capillary or venous pH and PCO2, plasma sodium, potassium, urea, and creatinine, plasma bicarbonate. Consider a near patient blood ketone beta-hydroxybutyrate testing method for rapid diagnosis and monitoring of DKA in children and young people in hospital. Children and young people with DKA should be cared for in a facility that can provide the level of monitoring and care for DKA specified in these recommendations. Children and young people with DKA should be cared for with one-to-one nursing, either on a HDU, preferably a pediatric unit, or a general pediatric ward if they are younger than 2 years, or they have severe DKA, pH level less than 7.1. Think about inserting a nasogastric tube if a child or young person with DKA has reduced level of consciousness and is vomiting. Fluid and insulin therapy. Treat DKA with intravenous fluids and intravenous insulin. If a child or young person is not alert, is nauseated or vomiting, or is clinically dehydrated, do not give oral fluids to a child or young person who is receiving intravenous fluids for DKA unless ketosis is resolving, they are alert, and they are not nauseated or vomiting. For children and young people with DKA who are clinically dehydrated but not in shock, give initial intravenous bolus of 10 mg per kg, 0.9% sodium chloride over 30 minutes. ml per kg over 30 minutes. Okay. Discuss with the responsible senior pediatrician before giving more than one intravenous bolus of 10 ml per kg, 0.9% sodium chloride. Only consider giving second 10 ml per kg 0.9% sodium chloride intravenous bolus if needed to improve tissue perfusion, and only after reassessing their clinical status. I think the reason you want to be so conservative in resuscitation fluids in somebody with DKA is because in children they are prone to cerebral edema if you correct the fluids too fast. So normally in other conditions, right, you will correct 20 ml per kg in 15 minutes, right? However, in DKA you give 10 ml per kg in 30 minutes. So you give half the volume at 2 times the time, the duration. And you should consult senior before giving further boluses. And only give bolus if it's needed to improve tissue perfusion, such as maybe their blood pressure is crashing, then you need to give. When calculating the total fluid requirement, subtract these initial bolus volumes from the total fluid deficit. For children and young people who have signs of shock, that's weak, tready, no volume pulse, and hypotension, give an initial intravenous bolus of 20 ml per kg, 0.9% sodium chloride as soon as possible. Okay. When calculating the total fluid requirement, do not subtract this fluid bolus from the total fluid deficit. Okay, so if signs of shock, you want to give the normal 20 ml per kg over 15 minutes. Example is if they have weak tready pulse, they have hypotension. Be aware that shock is rare in children and young people with DKA. Prolonged capillary refill, tachycardia, and tachypnea are common in children with moderate to severe DKA, but this does not mean that the child or young person is in shock. There are signs of vasoconstriction caused by metabolic acidosis and hypocapnia. Calculate the total fluid requirement for the first 48 hours in children and young people with DKA by adding the estimated fluid deficit to the fluid maintenance requirement. For the fluid deficit in mild to moderate DKA, blood pH of 7.1 or above, assume 5% dehydration. So a 10 kg child needs 500 ml, 5%. So 1 kg is about 1 liter. Five percent of 10 kg is 500 ml. 5% of 1 kg is 50 ml. Yeah, so if 10 kg is 500 ml. In severe DKA, blood pH below 7.1, assume 10% dehydration. So if 10 kg child, it will give 1 liter. Aim to replace the deficit evenly over the first 48 hours. But in critically ill children and young people, discuss the fluid regimen early with the senior pediatrician or pediatric intensivist, or both, because the risk of cerebral edema is higher. For the fluid maintenance requirement, use the holiday cigar formula. Give 100 ml per kg for the first 10 kg of weight. Give this per day, right? But over 48 hours instead of 24 hours. Holiday cigar formula, give 100 ml per kg for the first 10 kg, give 50 ml per kg for the second 10 kg, give 20 ml per kg for every kg after this. Use a maximum weight of 75 kg in the calculation. When calculating the total fluid requirement, subtract any initial bolus volumes from the total fluid deficit unless the child or young person is in shock. Use 0.9% sodium chloride without added glucose for both rehydration and maintenance fluid in children and young people with DKA until the plasma glucose concentration is below 14. Be aware that some children and young people with DKA may develop hyperchloremic acidosis. A persisting base deficit of low bicarbonate concentration despite evidence of resolving ketosis and clinical improvement. Hyperchloremic acidosis, but this resolves on its own over time and specific management is not needed. Include 40 millimoles per liter or 20 millimoles per 500 ml of potassium chloride in all fluids except the initial intravenous boluses given to children and young people with DKA unless they have anuria or their potassium level is above the normal range. Do not delay potassium replacement because hypokalemia can occur once the insulin infusion starts. Okay. For children and young people with potassium levels above the normal range, only add 40 millimoles per liter or 20 millimoles per 500 ml potassium chloride to their intravenous fluids if the potassium is less than 5.5 or they have a history of passing urine. For children and young people with DKA who have hypoglycemia at presentation, include potassium chloride in intravenous fluids before starting the insulin infusion. Monitor sodium levels throughout DKA treatment and calculate the corrected sodium initially to identify if the child or young person has hyponatremia. When monitoring serum sodium levels in children and young people with DKA, be aware that serum sodium should rise as DKA is treated as blood glucose falls. Falling serum sodium is a sign of possible cerebral edema. Really? Serum sodium. Falling serum sodium. Cerebral edema. But if water flows into the brain, shouldn't the sodium in the blood become more concentrated? Unless sodium also crosses the blood-brain barrier? Falling serum sodium. Just keep that in mind. A rapid and ongoing rise in serum sodium concentration may also be a sign of cerebral edema caused by the loss of free water in the urine. Do not give intravenous sodium bicarbonate to children and young people with DKA unless they have compromised cardiac contractility caused by life-threatening hypokalemia or severe acidosis, and you have discussed with the pediatric intensivist. Do not give children and young people with DKA additional intravenous fluid to replace urinary losses. Start an intravenous insulin infusion 1 to 2 hours after beginning intravenous fluid therapy in children and young people with DKA. If a child or a young person with DKA is using an insulin pump, disconnect the pump when starting intravenous insulin therapy. Child or young person with DKA is using an insulin pump. When treating DKA with intravenous insulin in children and young people, use a soluble insulin infusion at a dosage between 0.05 and 0.1 units per kg per hour. Do not give bolus doses of intravenous insulin. In discussion with diabetes specialists, think about continuing subcutaneous basal insulin in a child or young person who was using a basal insulin before DKA started. When the plasma glucose concentration falls below 14, in children and young people with DKA, change the fluids to 0.9% sodium chloride with 5% glucose and ST5 and 40 millimoles per liter or 20 millimoles per 500 ml of potassium chloride. If a child or young person's plasma glucose falls below 6 during DKA treatment, increase the glucose concentration of the intravenous fluid infusion. And if they have persisting ketosis, continue to give insulin at the dosage of at least 0.05 units per kg per hour. If the blood beta-hydroxybutyrate level is not falling within 6 to 8 hours in a child or young person with DKA, think about increasing the insulin dosage to 0.1 units per kg per hour or more. Think about stopping intravenous fluid therapy for DKA in a child or young person if ketosis is resolving and their pH has reached 7.3 and they are alert, and they can take oral fluids without nausea or vomiting. Discuss with the responsible senior pediatrician before stopping intravenous fluid therapy and changing to oral fluids for DKA in a child or young person if they still have mild acidosis or ketosis. Do not change from intravenous insulin to subcutaneous insulin in a child or young person DKA until ketosis is resolving, they are alert, and they can take oral fluids without nausea or vomiting. Start subcutaneous insulin in a child or young person with DKA at least 30 minutes before stopping intravenous insulin. For a child or young person with DKA who is using an insulin pump, restart the pump at least 60 minutes before stopping intravenous insulin. Change the insulin cartridge and infusion set and insert the cannula into a new subcutaneous site. Oh, there's a lot of information on this single page. So, in a child coming in with DKA, you want to give fluids, but you can't give fluids too aggressively because children compared to adults, they're more prone to cerebral edema. So what you want to do is give conservative bolus. And what is conservative bolus? The normal bolus in children is 20 ml per kg over 15 minutes, right? In adults, it's usually 500 ml over 15 minutes. And children, you need to calculate the actual volume, 20 ml per kg over 15 minutes. However, in DKA, if the patient is not in shock, where children is rarely in shock, but if they are in shock, you can see their hypotensive capillary refill time is prolonged. That's if they are in shock. Then you have to give the bolus 20 ml per kg over 15 minutes. But if they are not in shock, DKA, you give 10 ml per kg over 30 minutes. So half the volume, twice the time. And then only give further bolus if you need the bolus to maintain perfusion, or you already discussed with a senior pediatrician. And then after that, you want to start them on the replacement and maintenance fluid. Replacement fluid it depends on the severity of the DKA. So DKA is divided into 3 severities, that's mild, moderate, and then severe DKA. Mild DKA is pH between 7.2 and 7.3, and bicarbonate between 10 and 15. Then moderate DKA is a pH between 7.1 and 7.2, and a bicarbonate between 5 and 10. And then severe DKA is a pH below 7.1 or bicarbonate below 5. So depending on the severity of DKA, if mild or moderate DKA, assume 5% dehydration. So if you think about the dehydration category, you have not dehydrated, you have clinical dehydration, and you have shock. So clinical dehydration is 5%, shock is 10%. So if mild, moderate DKA, assume 5% dehydration. So in this case, you're going to give 50 ml per kg over, usually the replacement is over 24 hours, but in DKA you give over 48 hours. Again, the same reason being cerebral edema prone in children. In children, especially in DKA. So 5%, 50 ml per kg per 48 hours for replacement. However, if the patient is in severe DKA, which is pH less than 7.1 or bicarbonate less than 5, then you will want to assume a 10% dehydration. So 10% is 100 ml per kg per 48 hours. So that's your replacement, and then you want to give maintenance as well. You want to calculate replacement, you want to calculate maintenance, add them together and give with potassium with insulin infusion. So you have the You have the replacement. Now you want to calculate maintenance. Maintenance is using the Holiday Seagull rule. Holiday Seagull rule is 100 ml per kg for the first 10 kg. Is it per 24 hours? Yeah, I think so. Or is it 48 hours as well? Where's the Holiday Seagull? Holiday Seagull. Deficit over first 48 hours. How about maintenance? Maintenance is, they didn't mention, but usually it's 24 hours lah. I don't know they change it or not. So 100 ml per kg for the first 10 kg, then 50 ml per kg for the next 10 kg, and then 20 ml per kg for the subsequent kgs over 24 hours. So you're going to calculate everything and then add them together and then add potassium chloride. Potassium chloride should be 20 millimoles, 28 millimoles per 500 liters, right? Or 40 millimoles per liter. Yep, potassium chloride to all the replacement and maintenance fluids. Because if you give insulin, you drive potassium into the cells. You want to prevent hypoglycemia, you need to give potassium replacement. Only stop giving potassium in your fluids if their potassium is more than 5.5. What else you want to give? Insulin. You give insulin at a rate of 0.05 to 0.1 units per kg per hour. And then when you give the fluids, you expect the glucose to fall, right? Because you're diluting the blood. So when you're giving insulin, you expect the glucose to fall. So when the glucose falls below 14, when the glucose hits 14, you're gonna switch the fluids into NSD5. So 0.9% sodium chloride plus dextrose 5%. Or is it dextrose 10%? %5 glucose, so dextrose 5%, NSD 5. Yeah. And then how do you wean them off of your continuous insulin infusion? Is when they are alert, they can tolerate drinking orally without vomiting. And what's the other criteria? Ketosis resolving, means their blood pH reach 7.3, means go above 7.3. Ketosis resolve, alert, can drink without vomiting. Then you want to, before you wean them off of the continuous insulin infusion, if they are taking subcutaneous one, you want to stop the subcutaneous one 30 minutes before you wean off the continuous infusion. If they are taking the, what's that device called? If they're using a insulin pump, then you want to start that 1 hour before you wean them off the continuous insulin infusion. Yep. Alright. Wow, that's a lot. Pediatrics. So for pediatrics, DKA is a little bit different from adults. Oh, it's already 1 hour. Okay, we only did 4 questions today. Anyways, quite productive. Managed to learn the management of DKA and pediatrics, which is quite important. I guess I'll see you in the next one. Bye.